this particular hour, we want to talk about the Social Health Insurance Fund. And to help us have this conversation is the chairperson of the Social Health Authority, Dr. Abdi Mohamed. Daktari, a very good morning to you and welcome to Radio Generation.
Thank you very much. Dr. Abdi Mohamed is my name. And yes, the people's insurer.
Yeah. Indeed, you are.
If this is the people's breakfast.
Actually, Daktari, help us understand.
Yes.
Because Kenyans usually just know one word, SHA.
Yes.
But of course, there is SHIF.
Yes.
So maybe help Kenyans understand the difference between the two, or if indeed they are the same, one and the same thing.
Okay. So the Social Health Authority is the organization. And previously what we had was the organization and the fund were the same. NHIF, the organization, NHIF, the fund. But for this new dispensation, the organization is called the Social Health Authority. So under its mandate is 3 funds. So it has the first fund, which is Primary Healthcare Fund. And then the second fund, which is the Social Health Insurance Fund. And then there is the ECCIF, the Emergency Chronic Critical Illness Fund. Mm-hmm. So so for the first fund, which is primary health care, it's tax funded. So it means every Kenyan is entitled to it without contributing. So the only thing that's required of you is just to register. And when you register that, then now you are entitled to primary healthcare services. What is these primary healthcare services that we talk about? So it's your outpatient needs, where you don't need to be admitted. You just need to go to a hospital, get services for your homa here and there. Malaria, whatever basic needs that does not need you to be admitted, those are the things that you go to those facilities. And we have capped that services to 3 levels of hospitals. That is level 2, level 3, and level 4. So that means that you can go to a level 2, a level 3, and a level 4, get your primary healthcare services, but you must have registered.
Okay. And
the registration is very simple. From your phone, all you need to do is *147#, or go to afeyangu.go.ke, or go to sha.go.ke. You'll be able to get all the options to register. When you register, please, my appeal to Kenyans is add your dependents. Because people usually forget that they register themselves, then they forget their children.
Okay.
They forget their wives or their husbands. So it becomes an emergency the day you go with your child to a hospital.
Yes.
Then you are told they are not there. Now the process becomes, at that time it's tense. You don't know, there's a downtime a little bit. It becomes chaos. So we keep on begging Kenyans, always make sure your people are added under your profile.
Yeah.
If they are your dependents, just add them. At your free time, when you are not under any pressure, you are just in the office, log into your profile, just to make sure you have added your children. So the second is,
yes, on that first one, before we move to the second one, on the first one. So if I need those services, I can walk into any hospital, public or private, or are the services offered in the public hospitals alone?
So you can walk into public, private, mission hospitals contracted by SHA.
Okay.
So it's not any, as the word suggests. So it's only facilities that have been contracted, who have been contracted to provide PHE services. Those are the ones. And they are across in terms of ownership. Mission is the ones owned by the churches, and then the private sector and public sector. For public sector, I can easily say all.
Okay.
Level 2, 3, 4. All of them. For the other categories, it depends on the owner's decision, whether they have been onboarded or not onboarded.
Okay.
So it's any of those facilities.
And you have said, for example, let's, God forbid, nitoke hapa nje and I'm hit by a motorcycle. And I've probably sustained a cut on my arm. I can rush to that primary healthcare facility, get treated absolutely free of charge and walk away.
Now that comes in the third fund.
Okay.
You have jumped. Which is ECCIF. So under ECCIF, actually, you don't even need to register. Under emergency circumstances, registration is not necessary because that's what you're entitled to under the Constitution. I was going to the second one, which was the SHIF.
Okay.
So the Social Health Insurance Fund is a member's contribution based. So it's 2.75% of your total income. Is what you pay on a monthly basis.
2.75%. 2.75.
And it is on your ability to pay because it's based on your income. So it means if your income is 10,000, it's the 2.75%. If it is $1 million, it's the 2.75%. So the contribution varies based on income. One person will pay 27,500, another one will pay 300 shilling. But in terms of benefits, you're entitled to the same. And that's the whole essence of social health insurance. That's why it's called social, that we contribute equally. We contribute based on our ability to pay, and we get benefits equally. There is equitable in terms of services. Then the last one is ECCIF, Emergency Chronic Critical Illness Fund. That's also tax funded. So emergency, you're entitled to everyone. Anybody within the Republic of Kenya is entitled to emergency.
Even foreigners?
It doesn't matter.
Okay.
It doesn't matter whether you are a foreigner. It doesn't matter whether you have registered. It doesn't matter whether you have not registered. The emergency bit, you are entitled to the first 24 hours for any of the services that you require. Then subsequently now, your other either cash or your SHIF comes in or your private insurance after that. And that's where now we are heading to start the ambulance services, which hopefully will be up and running before the end of the year, if not early next year, so that we have, as a Kenyan, that when you need an ambulance services, you're able to call a national toll-free number, and then an ambulance it is dispatched to wherever you are, and then it takes you to the nearest emergency center that can give you services at no cost.
Yeah.
At the services because of the fund that we receive from Treasury.
Yeah.
Yes.
So that is now where I was asking if, in case I get hit by
so in case now the ECCIF, that's where it's built. So the hospitals now the differentiations that this is an emergency as under ECCIF, but you are just at home, you're not feeling well, or you have been here the whole day working, then in the evening you feel like some fever, you need to go and see a doctor, you need some sort of treatment. Now that's PHC. And that's where now registration is required. That you must have registered for you to benefit that services. Yes.
Okay. So for example, let me give you an example. I have a relative who a few months ago had to be admitted at one of the hospitals here on Ngong Road. And she had spent a bit, I think it was about 5 days if I'm not wrong, but at the point of discharge there was an issue with SHA. What, first of all, of which of the three was she under? Was it the first, the second, or the third?
Was probably under SHIF. If she was admitted for long,
yes,
then it's neither, because it's already an admission. So PHC is out.
Okay.
PHC is for walk in, walk out. Okay. Then SHIF is where now you have been admitted. It means means you are a contributor.
Okay.
And the last one is emergency. It's the first 24 hours and it's over.
Okay.
So all the subsequent days have to be covered under SHIF.
Okay.
So what was the issue? So that
alikuwa melazwa tu, alikuwa na infection fulani, then akadischargewa baada ya siku kama 5 hivi, lakini wakati wa kutoka pale, I think the issue was late registration with SHA, so it wasn't really an issue per se. It was just about registration.
Okay. So this is the challenge that we face as an authority, and in insurance term, it's called adverse selection. So adverse selection is where an individual gets a cover post the fact
of admission.
Yes. So you get it's like you drive your car, you get hit on an accident, then you say, wait a second, I forgot, I didn't have an insurance. Let me get an insurance, and then it's covered. So what happens is some people are applying or registering after they have been admitted in hospital for 2 days, 3 days, 4 days. So then their expectation is it's paid. You can never backdate.
Okay.
After at admission, if you did not have, you did not have. If you are not covered, you are not covered. If you did not register, you did not register. So then now that's where problems start. People say, oh, you know what, I registered and now people are, but you paid it today when you're about to be discharged. And then you realize your premium is, let's say, 6,000 for the whole year. And then your bill is
50,000,
300. And then you are told, if you had SHA, actually that's what the hospitals should tell people, so that they understand the importance of this doing prior. 250 would have been paid by SHA. So then now you start thinking, let me be smart and register. And then now I start making noise saying, oh, we have registered and it's not working. It's not working. This thing, it's unfair. It's unfair to all the other contributors for you to just step in when you are sick and you need the services. Because you need to ask yourself, where is the other 244,000 coming from?
Okay.
It's other people who have been contributing. So what we need as a nation is that you don't know. The challenge with health is you never know when you need it.
True.
You never know. And unfortunately, it's one of the most expensive things that you can live with. It's easy to deplete a family's resources by just having one person falling sick. And that almost always puts a family into poverty. And studies show that almost 1 million to 2 million people are pushed into poverty every year because of sickness.
Actually, there's a saying among Kenyans, wanasemanga, you're one disease away from poverty.
Exactly. And it's because of you never know what's going to happen, when you will fall sick, when you will need. And hence the reason why we should have all contributing, whether you look healthy, whether you look young, whether you look old, you don't know when you need it. When we all contribute, what that does is it actually increases the benefit package. Because now as an authority, and I will come to it, there is now a whole committee based at the University of Nairobi with scientists who are doing the numbers to say if we need to cover this disease from this point to this point, if we need to add this new benefit, if we need to increase the current rate from this to this, these are the numbers that we need in terms of people contributing, the total contribution to be this amount. So there is an opportunity for us as a country to improve even our benefit package to Kenyans. But that can only happen if everyone steps in, contributes, and your contribution is based on your ability. No one is telling you to pay 20,000, 30,000, 40,000. So you pay as per your ability to contribute.
Right. Let me ask the question.
Yes.
Are you saying that people who have paid in advance prior to any illness that gets them admitted to hospital, that these are people without exception will actually be served and will get the cover they paid for?
Not really.
So just walk us through it so that we understand the permeations, and so that when somebody goes to hospital, they understand that the situation that you are in is this and that and the other.
Okay. So so you register today.
Yes.
You contribute.
Yes.
Anytime you fall sick, you will get services.
From if I register today and I fall sick tomorrow,
you will get services.
I'll get the services.
Yes.
All right.
You get. You have registered 1 year ago. You have been paying. You are up to date. You need services. You will get services. You fall sick, you will get services. But what you will not get is you have been admitted in a hospital. You are in a hospital. Day 1, day 2, day 3, day 4. On the day of discharge is now when you want to register.
Oh, you. No.
Even now, even you agree.
I do agree. I just want to understand, because...
So you want to register on the day you are leaving the hospital, then you want the hospital and SHA to backdate the payment. So then they pay for you all these 5 days you have been in hospital.
It goes against the very principles of insurance. The insurance is you pay before it actually happens, so that when it happens, whatever it is, the cover is in place. So now all you're doing is enforcing it.
Thank you, and you hit it on the head. That's what we are trying to say. Even sometimes, this is the other problem that we also face. You have been paying diligently for the last 1 year, but you have never added your dependents. You get admitted. On the day of discharge is when you want to backdate the addition of your dependents.
Okay.
You see, that now is picked as an adverse selection.
Who qualifies to be my dependent?
Your children and your spouse.
Okay.
Yes.
What is the age limit of these children?
Up to 18 if they are not in university. If they are in university, up to the 25 years. If they are disabled, no age limit. So those are the people who are allowed to be added as your dependents. Spouses as well. Yes.
Yeah,
and it's 1, 2, 3, 4.
How many am I allowed?
4.
Very good.
Can my aged grandmother, for instance, be my dependent?
No, she's a household on her own. Yes.
What if she lives under my roof? I take care of her. Yani basically, kila kitu ni mimi.
Yes. Still, it's just one household.
It's you, wife, children. That's it.
Yes.
Okay. Uncle, auntie. Different households.
No. Those are different households.
Parents, different households.
Different households. Those are households on their own. So the children are also the ones that you are guardianship. They are also allowed.
So if I'm staying with my cousin's children, because my cousin is no longer there, those are also...
now you just need to get the documentation right.
And present. Okay.
Yes.
So you've just said that in terms of dependents, I can have up to 4.
No, 4 spouses.
Or 4 spouses. And our children.
Children can be as many.
As many as we have. Okay. I just need to confirm that.
Yes.
Because we are a polygamous culture. Society rather. Na kuna watu wanaweza kuwa na mabibi wengi sana.
So don't be pressured. So you can in choosing one.
Paul, unaambia usiogope.
No. Mimi siogopi. 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 Mwenye niko naye ndiye anaogopa. Now, in terms of, there was a question, and I think I saw something in the papers either last week or the week before that.
Yes.
There's some increment of sorts that SHA has done as far as cancer treatment is concerned. I'm a bit scanty on details.
Yes. So the reason why we set up the ECCIF and it's tax funded is because we realize that there are certain conditions where your benefit under SHIF is not enough. You are more likely to deplete it.
Yes.
And then when you deplete it, what happens? Previously, you are left on your own. You look for other ways. You had a cover, you depleted it, imeisha. So what the ECCIF is supposed to do is to help you with the excess loss. So you have depleted your benefit. Now this becomes like a cushion. Okay, how do I now benefit? So you have a limit under SHIF, then under ECCIF, because you have exhausted your limit under SHIF, ECCIF kicks in and helps you address that exhaustion. And the first condition that we have put under it is ICU and cancer. Those two, because under SHIF ICU we pay 4,500, but that is in level 6 hospitals, the usual bed rebate. But because we have realized that 4,000 for an ICU is not reasonable, we opted to increase that limit to 28,000 under ECCIF. So now every night for ICU, 28,000 comes off. SHA pays for every patient who is in ICU, including neonatal ICU.
Okay.
For cancer, there's another 150,000 that has been added, and there is still
150,000 is for what period of time?
No, it's for the whole year.
Okay.
The premium usually runs a year. Your policy is beginning of the year when you have started to the end. So you finish first what is under your benefit under SHIF.
Yes.
When you finish it, anytime, sometimes you could finish the first 2 months, sometimes you finish at 9 months and the treatment is still ongoing. Then now you continue. After the year is over, your benefits reset to zero again. You start from the beginning. So it's a new financial year. Your benefit now becomes full again. So it doesn't end. And that is also important for patients with chronic conditions. For acute conditions, it's okay. But for chronic conditions, your treatment does not come to an end this year. Sometimes it's continuous. You need to continue being treated next year, the other year. It's something that goes on. So you need your limit again to be replenished. And that's how now the ECCIF comes in. If you finish it before the year ends, now that's where you will have to step in. And that's what we are trying to see. How do we improve this limit? Or maybe in the long run, have no limit. When you kick into ECCIF, it continues until the financial year is over. Because that way, you at least feel that there's nowhere you will be dropped because you are on treatment.
People who are on dialysis have a certain number of days that they must go for this process and procedure.
Yes.
What is the fund paying for now? And under what you're saying, what is under consideration, what do you hope to pay for?
So currently, dialysis patients are entitled to 2 sessions a week for the whole year.
So 2 sessions
every week
for a whole year.
For a whole year.
Okay.
Under their SHIF contribution.
Yes.
And this daktari is at a hospital of their choosing or public?
A hospital of their choosing, including Nairobi Hospital, wherever you live nearby, because luckily dialysis is available across the country.
Okay.
If you go to even Mandera, there are dialysis centers. If you go to Wajir, there's dialysis center. If you go to Marsabit, go to Turkana, the farthest corner in this country, you will find dialysis centers. So it is any facility of your choice. And then we pay for those two sessions 10,650 shilling per session. That makes it 21,300
okay,
per week. So in a month we pay 84,000, around 86,000 in a month. And this is a person who has contributed whatever amount. It could be 300 shilling, 500, 700, 1,000 shilling. We will pay that 80-something thousand per month. So now there are sometimes patients who might need an extra session in a week. So that's where now we need to go take that to the ECCIF, so that you get that one extra session, and it's not so continuous. There might be very few patients who need 3 at the minimum every week, but the number is few. The bulk and the majority of them, 2 sessions is reasonable enough to get the treatment. But more importantly, for those who don't want now to continuously engage in dialysis, there's the option of transplant, which we pay for.
Up to what? What's the limit?
For transplant, once, if you go for transplant this year.
It's a one-off?
Yeah, it's a one-off. But it's a one-off for this year. The next financial year, if you need transplant, again, we will pay. The other financial year, if you need another transplant, we will still pay.
Is there a ceiling?
The amount, yes. The amount is there. But we have hospitals that we have negotiated with. That now, if you go and you have SHA, you don't need to top up any shilling.
Everything is covered by SHA?
Everything is covered by SHA.
How widespread are these hospitals across the country?
Even transplant is not widespread.
No, transplant is definitely not widespread.
So you will find the number of hospitals that are able to do transplants in this country are not beyond 6.
They are 6?
Yes.
Okay.
So all the major public hospitals, the level 6s, that's Kenyatta, KUTRH, and maybe MTRH. Then you have the Aga Khans, the Nairobi hospitals. Those are now the ones that have those transplant, and maybe another 1 or 2 in Eldoret that are able to do transplant. So one of the agreements that we had signed, so for us, you see, we try to look at where can this be provided. So public hospital is an issue. What we need to find out is which other private hospital can be onboarded so that they also remain within this limit. Aga Khan was the first hospital that stepped up and said, with transplant, we will not go charge as long as the person is covered by SHA. And we signed an MOU. So the expectation now is there will be few people who will now step up to take that offer and proceed and get the transplant done locally. Yes. The principle on which insurance tends to work, one of them is pooling. Yes.
You have many people over a period of time coming in. So my question here is, are all civil servants under SHA?
Yes. Anyone who is employed, including His Excellency the President, contributes to SHA and is a member of SHA.
Military?
Yes.
Teachers?
The military on their own have, you don't get their salary contributions, no.
But are they
military, no.
Are they insured under SHA?
You know, they have their own hospitals.
No, they have their own cover, medical, their own. They are not.
Okay.
They are not civil servants.
They are not civil servants.
What are they?
Discipline forces.
They are military workers.
Police officers?
Yes.
Teachers?
Yes. everyone,
You see,
the CSS, PSS.
You know where I'm going with this?
Yes.
I'm asking. There has to be a critical number that is needed for the contributions to be at a point where they can actually meet the demands that we're speaking of here.
So for me, what we need is if every Kenyan contributes, those who can't afford, there is the indigent, and government has already paid for around 2.3 million.
What do I need to do to be indigent?
No, I don't think there is anyone who would like to be an indigent. It's just circumstances.
Yes.
But you will find most of the time it's elderly people who. So the Ministry of Social Protection is the one that identifies individuals who need help. Either government subsidy for the usual monthly reimbursement or any other services. So one of the other services that they need is health. So they pay for their shift contribution. But remember, those people, their PHC, all they needed was just to register, so they didn't need to contribute. But now they also get the shift cover as well. So now they are entitled to the full spectrum under SHA for all the three funds. So indigents are paid for, but the rest of Kenyans who can afford in one way or another actually need to contribute, and when you contribute, now that is where you talked about the pooling, and it increases the revenue, the fund that we have, which now pushes our expands our benefit package to in such a way that many more hospitals are willing to make this benefit in and out, so that you don't have to do any out-of-pocket contribution. But as an institution, what we try now to find out is which are these big ticket items for the moment that maybe if you are told pay out of pocket will put you under distress or into poverty. Transplant is one of them. It's not easy to pay 2.53 million cash to a hospital. So now if you have the cover, at least you are assured of getting that without having to do any harambes.
And in terms of, because sometimes I could get a surgery if it's that kidney transplant, for example, and then my kidney or the kidney that I got is rejected by the body, so I need to either go for another surgery or some kind of procedure. Is that also covered?
Yes. The cover is still there.
It's limitless.
Yes. Oh. No. It has limits. It's not limitless. Anything that is counted
has a limit.
Cannot be limitless.
Cannot be limitless. Yeah. So it is. Yes, but it depends on what's the next surgery, how big is it, because we have categorized and we have put all those surgeries to say this is at this level, we are paying this amount, you are entitled to one of these, 3 of these, 2 of these. So it's clear. At that time you will be told yes, you need the second surgery, you can proceed.
Okay.
Yes.
All right. But in the case I can't, then now I need to go back to the drawing board. Yes,
but you see, for us even to expand that benefit, move from maybe 3 surgeries or 4 surgeries to 10. It's what CT said.
Yes,
that we need that mass, that many individuals to onboard and register. Now say, okay, I am contributing. Yes, today I might not be contributing.
Right.
I'm not sick. But tomorrow when I am sick, at least I am entitled to a benefit. And more so people who are at high risk. For example, you are a boda rider. Your risk of injuries is
very
high,
yeah,
compared to the normal individual who uses vehicles or does not use any motorcycle,
or who works from home.
Yes, but you will find still those are the same people who might not be contributing anything. And you see that now creates, then now they will register maybe after the accident. And try and contribute. But if every border guy actually registered, they will not have these challenges in terms of being put on traction in hospitals, like where they tie your leg and put some weight, and they are told it is 6 or 12 weeks for it to heal. Naturally, and then what happens is in those 12 weeks, as a border rider, you are not earning. Your family is waiting.
And even after those 12 weeks, I don't think you will still get back on the road.
Sometimes after 12 weeks, it's not yet haijashika. You are told we are extending another 6 weeks or 12 weeks. So what happens is at the end of the day, that motorcycle is sold, that family scatters. Now they are trying to contribute, trying to see, then they have a hospital bill at the end of those 6 months, which they have to offset. But if you had SHA, and you went, did any of the put in an implant, after 3-4 days you are discharged from hospital, another 2-3 weeks you are back to your normal life. That is the thing that people still don't realize, that this harambe, this pooling, is basically harambe. Is there's a better way of doing that harambe, not at distress time, but by just contributing regularly. Because you are contributing, don't wait to be added into these WhatsApp groups. It's better. Why are we forming our own private WhatsApp groups when we have this one big one under the Social Health Authority, where I contribute, you contribute, he contributes. And if there is any benefit people feel that they need to be added, you can easily go to that new the Benefits and Tariffs Committee and petition. They have started meeting with stakeholders. Yes. They have started meeting stakeholders to hear out what benefits do you want either to be scrapped, to be added, to be enhanced, so that as a country we take lead in what we need to prioritize. Yes.
There's some insurances if you've taken, I'm talking about the private one now, where in case of your demise they can provide a casket, or they pay for a hearse as well. Is that something that is in SHA or can be considered?
In the long run, yes.
Okay.
But for now, we are dealing with the
people are alive.
Yes.
Fair enough.
In the long run, yes.
One of the very big questions that Kenyans were asking when SHA was being rolled out is why NHIF had to be, rolled up so that SHA can have a life. Why not just include some of these other benefits that now we are discussing and continue calling it NHIF? Because NHIF, when it was rolled up, it went with a lot of things. People who are working for NHIF, sijui kama walifutwa kazi na bado wako kazi ama iko namna gani, but you understand what I mean.
Okay.
Yeah, so why couldn't we just maintain the good things of NHIF, get rid of the bad ones, and include the new ones from SHA?
But that's what we did. That's what exactly happened.
Okay.
So in 2017-2018, there was a committee that was formed, a task force, to look at what ails NHIF. And they came up with a report that said the NHIF we want, which was to suggest a radical shift from what we have been doing. We have been doing the same thing for the last 60 years. And it doesn't seem to be addressing some of the issues. So NHIF was the chief part, the Social Health Insurance Fund. So all you needed was you must be a member who contributes. There was no other benefit to any other Kenyan.
So it was 500 bob.
Yes, so it was a members club. So you needed to be a member and pay. If you have not paid your subscription, there was no benefit. But when you look at SHA, you realize there's the PHC, which is tax funded, which now puts every Kenyan on board, whether you have contributed or not contributed. You at least are entitled to a service at the minimum, outpatient. Then the second bit, which is also something that has been in law from the new Constitution 2010, emergency, under Article 42, says that you are entitled to emergency services. The Health Act of 2017 said the same thing. There was even an emergency policy document at the ministry level, but it has never been operationalized. 2010, up to now, with the new law that we passed, up to 2023. Now, that dream and vision needed to be realized. And the way to do is through the Emergency Chronic Critical Illness Fund, which now entitles you to emergency treatment without you being either a member or a contributor. That was also not available under NHIF. So that's why you will find that there was a need to remove, and then the contribution. If you look at contribution, people were paying different amounts. It was unfair to the young person, to the low earners. If you earn 10,000 and you are paying 500 shilling, basically what you are doing is you are paying 10% of 5%. For those who earn less than that, if it was 5,000 is what you get as your income, you end up paying 500. That's 10% of your income. But the person who was earning $1 million was paying 1,700. So to the highest earner, there was a capping. And actually that was from 100,000. So anyone who earned above 100,000 was told, no. You wewe ni mdosi 1,700. Hatutaki zaidi ya hiyo. So it means the contribution was pushed to the people who earn below 100,000. Because from there it was fixed 1,700. If you earn $1 million, $2 million, $3 million, it did not matter. So that was 0.0017% of your income. So when you look at in terms of the numbers, it did not make sense contribution wise. It was very unfair system, very regressive. When you look at while what you should aim for in any country is a progressive nature of taxation. Not regressive. Regressive, you are just pushing the low earners downwards. Then when you look at the issue of administrative fee, NHIF did not have a limit. So they could collect $1 billion and use 500 million.
When you say administrative fee, what do you mean?
Salaries, rent,
fuel,
vehicles.
There was no cap.
There was no capping.
Oh,
it was open.
So it was an open check. As many people as they liked, pay as they saw fit, and so forth.
Yes.
Oh dear.
So at one point, it was as high as it started progressively. Early beginning, it was 80%. Of the money they collect, 80% was for administrative. So it came down. The last time it was around 17%. So for every 100 shilling they collect, 17 shilling is for administrative fee. That is now where now you will find all these stories that you keep on hearing, that a lawyer was paid 70 million to recover 10 million. that you own a building but you rent the one which is next, and you live your own building but you pay rent
in the next one.
You that you find that you have 85 computers in a branch, and then you have 10 workers. So then you ask yourself, why did you have another 70 computers? What are they doing? So there was a lot of freeloading, if I would say. But under SHA, that has been capped to 5%.
Oh, really?
Yes, in law, in the act. Not feelings by board members, no. It's in the law. 5% maximum is what you can use to do your administrative work.
And is the 5% meet the needs that are there?
Yes. Hence the reason why now the issue of reducing the number of staff from 1,800 to 800. So that reducing...
That is countrywide?
Countrywide, yes. Reducing the branch network to a manageable 47. Investing in a call center where now people can actually call and make, rather than having physical offices. Using Huduma centers so that people can now, when they are looking for other services, they go to those Huduma centers and get SHA services as well. Doing most of it through your digital platform.
So, Daktari, what happened to the staff members that were reduced?
So the staff members that were reduced have been given two options. Those who want to go to the public service can go directly to public service. Those who want to remain will apply competitively with the rest of Kenyans, and those who are lucky will be appointed to SHA. Those who don't manage will go to public service and will continue earning the same salary. So they haven't lost their jobs.
So what you're saying is that there are actually three options.
Yes.
So option number one,
yes,
voluntarily say that you want to get into the public service.
Yes.
So that means that you are now redistributed in the public service network.
Yes.
Okay.
Yes.
So you could end up in treasury. You could end up in
interior. You could end up in KBC. You could end up in KRA.
Okay.
Anywhere.
Yes. Then there are those who now want to apply to remain in SHA.
You go through the competitive process of recruitment.
So you are recruited, and then my brother here, City, isn't recruited.
So you remain. City now will go back to public service. Will join the others who opted.
So my benefits, or rather his benefits,
remain the same.
So the years of service that he has given to the government,
his pension remains the same. So nothing changes.
Okay.
Basically, it's just your workstation that has changed. You left your old building NHIF.
Yeah.
Now you are in the Ministry of Water, Ardhi House, which is next.
Transfer of services.
Yeah, exactly. Or you have gone to Ministry of Health, Afya House.
Yes.
That's where you have moved to. So it's only your location that changes, but your benefits, your salary, all those things remain constant.
So
yes.
if City applies competitively with me,
yes,
now we are applying for this position.
Yes.
And then I am lucky enough to get it.
Yes.
Do my benefits change? My salary, does it?
Why is it you who gets it? Why
not City?
Why can't I get it in this story?
Okay, so City gets it.
Thank you. That's a better scenario, yes.
So City will now be onboarded with the new terms of the new Social Health Authority.
Okay.
And you see that one is voluntary, no one has forced him.
Yes.
He has the option of leaving. So sometimes the new terms could be better than what he was earning.
All right.
Maybe you are just an officer who never been promoted because there were people who are holding those positions. But now you have a chance to compete with your former boss. You come and convince the board that you feel you are the right candidate, you know your stuff.
Yeah.
So you might end up getting an increment in salary because you are earning lower, but now you have moved into a little bit higher position.
Yeah.
Sometimes you might be earning the same where you are now, and the position you have applied for is the same, so you will remain with the same salary and with the new terms of the authority. And the new terms of the authority is governed by SRC, the Salaries and Remuneration Commission. So they are the ones who say, this is your salary structure, this is what the CEO should earn, this is directors, deputy, assistant. So we have that limitation. Yes.
There's Mr. Ndungu Wainaina here asking, or rather saying, there are 4 types of healthcare systems in the world which meet the healthcare needs of the people. And they are the Beveridge model, the Bismarck model, the National Health Insurance model, and the out-of-pocket model, which is the Kenyan model.
A combination.
Exactly. Actually, he has answered. Yes. Because you see, out-of-pocket means that you are paying from your own mfuko. The National Health Insurance means like what we have.
Okay.
But what we have is a mixed model, because there is also tax funded part of it, which government is paying for PHC and ECCIF.
Yes.
But at the same time, there is the part of you contributing as well. So that's why you have a combination.
Yeah.
We have tried all those things. Out of pocket, people have been doing and they are still doing. We have tried the
Beverage.
Where now government pays. But unfortunately, there is no one system in the world that you are told is the best.
Okay.
You always need to find out what works for you as a country. If you look at even now today, counties are supposed to equip their hospitals and provide services from budget.
Yes.
But that has been before counties as well. National government was to have been equipped and provided services. But were we getting what we needed to get?
Okay. I said that I will read something coming through our YouTube channel. For instance, we have Naftali Midega saying biometric authentication is a nightmare at Jaramogi Oginga Odinga Teaching and Referral Hospital, where kuja upange line for 3 days at the CT scan ujue. Daktari, is this something that we're experiencing a lot? Because I've had questions of this biometric registration, or is it the use of biometrics? What is this all about?
So the idea is to cap on fraud, so that the person who is getting the services is you and not your relatives who is not registered. So yes, we have challenges. I will be lying if I told you that it's smooth, it's running, there are no issues. So there are 2 kind of challenges. One, you will find there are few patients maybe who have a challenge with their fingerprint reading. Those we call aged cases. So they need to be identified and they are whitelisted so that they go back to using OTP. And we know this is Abdi. His fingerprint cannot be read. It has one issue or another, and then they will be using OTP. But there are a few others where you will find the facility, maybe the gadget has an issue. Maybe they have only 1 or 2 service points rather than 5, 6 service points. I think that's something that we'll try and address. Hopefully it will come to an end. And once we find out, like now, JTRH, I'm sure the team who are listening will take the necessary action and find out what exactly is the issue.
Okay.
Yes.
Then we have here Kenson Mugolo saying, is SHA paying on maternity because Linda Mama was doing well?
Yes, maternity, SHA pays for it. So I don't know when someone says it as well, what exactly they mean. Because SHA pays higher than what Linda Mama was paying.
Okay.
Normal delivery, we pay 10,000. Linda Mama was paying 2,500. So cesarean section, we pay 30,000. Linda Mama was 17,500. So sometimes I know there are buzzwords people use. Unfortunately, the facts speak differently to it.
Okay.
Yes.
Then there's Mohamed Murunga. Mohamed anasema, SHA has always worked for me despite the negative noises. Not perfect, but let's embrace it. Let me ask you,
yes,
from where you sit as the chairman,
yes,
what are some of the negative noises that Mr. Mohamed is talking about, and how are you tackling them?
So there are many noises that are around SHA.
Yeah.
As I have told you, if I close an office and you are the landlord, and I move to my building,
yes,
of course you will not be happy. If I reduce my expenditure on printing, on other things that I have been doing or NHIF used to do, because now I'm capped at 5%, there will be noise. If you are a hospital, maybe you are engaging in fraud, and then now I am able to finger point and say, okay, an action is being taken. You are taken to DCI and the process kicks off.
Yeah.
You will not be happy. So there is a lot of challenges. The noise, some genuine. For people, let's say you have gone, you are trying to log in your biometric, it's not working. Those ones are genuine concerns. Those are things that we try operationally to address. But when you pick the other noise, sometimes you realize it's not coming from a point of facts. It's coming from a point of some people with other agendas. Currently, we use, for all our cases, we use the AG's office.
Okay.
So that means we are not onboarding any law firms.
Okay.
We are not onboarding any new suppliers for other different things. Because we have to try and limit ourselves and set aside 95% to pay for people's care, and put ourselves within the 5%, try to maintain our administrative fee within that. So genuine concerns, we pick it, we address them regularly on a day-to-day basis. We go through, because people call our call center, so we always have what are the main issues. Sometimes most of them you will find is educational issues. How do I add someone? How do I change my phone number? Because the phone number that is in the system is not, I'm not using it anymore. How do I contribute? So those are the basics that we are trying to see. How do we address them regularly?
During the strike that we had in Kiambu County, is it over?
Yes, it's over.
One of the issues, because we sat here with several doctors from Kiambu, one thing that came out from their conversation is that they are not insured. So I do help me understand what they meant by that, because we CT here was asking, are the military in here, the police, teachers? So are doctors insured under SHA?
Yes.
Okay.
So this is for counties, I think there are two things. So you see, SHA is a statutory deduction. It's a requirement by law that your 2.75% of your salary is deducted and given to SHA. But doctors, like all other employees, have CBS and agreements with counties or employers for people who have unions. So one of their requirement is that they are put on another medical scheme other than what they have generally. The statutory is not counted, so they ask for an extra. But sometimes the challenge we face with the counties is there's a delay in payment to SHA. From counties, from parastatal, from even private entities. So what happens is the system automatically cuts you off until your employer reimburses. So when there is a delay and the system says you are not eligible
because you haven't paid,
because your employer hasn't remitted, but they deducted from you in one way or another, or they haven't paid you even salary. So of course, under SHA, you will not get services. It's just the rule. And you have 9 days to pay, 1st to 9th of every month.
So if
from 9th up to 9th, if your employer hasn't remitted, then on 10th, you are not eligible.
Is it possible for me to remit?
No. You are an employee. You're not self-employed.
So let's say my employer for whatever reason is having challenges. Pia yeye mahali pesa inafaa kutoka anilipe iko na shida. But niko na
now that is where hustle. Now the usual noise comes in from people who are employed formally. Because they feel that it's not their fault. But also for us, what happens is if we don't collect, we run into
problems,
outstanding debt.
So there is
now outstanding debt trying to recover becomes a challenge.
So a good Samaritan like City says, mbuvi hujalipua SHA, wacha nifanye hivi miezi ngapi 3, wacha nikulipie miezi 3.
Sasa mbuvi City needs to come and pay for through the payroll all the pending.
So when you're self-employed, Daktari,
yes,
what documentation do you need to present so that it can be understood that what you say you earn is actually what you earn?
So you do the self-registration, you say you are not employed and no one has declared you anywhere as an employee.
Yes.
So then you do the proxy means testing.
Proxy.
Yes. So the means testing is where now we look at your income. So there are questions that you will answer.
You look at the income I have told you I earn.
Yes.
I see.
So, but you are not telling me that you earn 1 million. No. I will ask you, have you gone through those questions? They are around 40.
Yes. I personally have because I registered.
So you start from what do you do, level of education, where do you live? There are many questions that you will answer. So out of that many questions, there's a mathematical model that runs and gives an estimated income.
So you're going to decide for me what I should earn?
No. We are estimating. We are estimating your income and telling you this is your estimate. Based on this estimate, you should pay 1,000 shilling or 500 shilling or 600 shilling monthly.
The socio-economic status that I would have, according to you, is determined by the details I will give in this questionnaire.
Yes.
I see.
Yes.
So essentially, you'll still be telling me what you think I should earn.
No. It's you who has told us.
No, it is you who has decided that from the information I have given you, it equals this.
Yes.
You see, because again, I went through that system. I really can't remember the details, but I remember some of the questions there. Of course, they were trying to determine, whether I have money or not.
Yes.
Because I remember somewhere I was asked, what was my M-Pesa balance? Or, such kinds of questions. But what if, and this is a what if question, I lie in this mean testing?
100% possible that you will lie.
Niseme mimi ninaishi mali.
So the model is also equipped to also pick discrepancies in your what you are saying vis-a-vis what else you have said within. So there are things that you will say you are thinking you are lying or you are lying genuinely, but kuna vitu zingine pia unasema which also don't tie.
Is this a system integrated in any way with the KRA system?
No.
Pity.
Yeah.
Because that would be the msema kweli.
No, but you see, not every Kenyan pays to KRA also.
Why I asked the question is I may not be paid a salary now, but I was once paid, so it becomes a good reference point. Yes, so with the KRA input, you have a fairly clear idea.
So there is a lot of data and information that it tries to aggregate. It's not perfect. It's not 100% foolproof to say that I am paying, but that's why also it has the option of appeal. If you feel you have been put at a higher,
there's an option.
Yes, you can appeal. You appeal. You say
if you can appeal at KRA, you can appeal here also.
Yeah. Okay. So the idea is not who pays the least. That's why this social health insurance is the ability to pay. So if you're able to pay whatever that you have been told, I think it's only fair that you also pay, because your benefit will outweigh what you are going to pay in any way.
You know, the discussion about payment is often augmented with a different discussion. The private insurer versus this
government one.
This utumishi kwa wote system. Now, there are arguments for both sides, and there are those who will tell you, but perhaps this is more of a Kenyan middle class construct where they will argue about something that they have benefited from, especially when they're in the corporate world. However, the thing that the diet on which we've been fed for the longest time is the negative aspects of SHA. Okay? Vis-a-vis what it is that the private service, the private insurance provide. Now, those of us who have both will probably have an interesting story to tell. Now, Daktari, do you ever come across individuals who, there are many who come out publicly and say, SHA did not work for me on this and this, but then those who say, actually it worked for me? Is it that the numbers are balanced? Is it that the numbers of people who are saying SHA is working for them is increasing? Because the tempo of noise that one heard, one doesn't quite hear. The people still complain, but the tempo is not the same.
Because the numbers, yes, I agree with you. Maybe the noise has gone down because the facts sometimes will find its way.
Yes.
The truth at the end of the day just comes out as time goes on. Unfortunately, the initial noise was with a lot of lies. But the beauty, you know, when you also respond to those lies, you are told, wewe ni wa serikali, wewe nyamaza.
Yeah, ndio.
So sometimes you allow action to speak louder than the noise. So yes, there is that has gone down, but I think there's still room for improvement on small operational issues that we need to address. Even those people, some of it is lack of education, lack of awareness, or what they have been told vis-a-vis what they are seeing. But generally, every day close to 30,000-40,000 people benefit from the shift.
On a daily basis.
That is the shift. If you go lower, it is the hundreds of thousands for PHC on a daily basis. So you see, those are human beings. They are people. They have relatives. They have friends. They have. So you cannot continue lying to them, because they will tell you, what do you mean? Our colleague has been paid for, our friend or my relative, my auntie, so they start realizing. Then the second one, where you talked about on issues of voluntary health insurance, not so much private per se, that's what's called in the lingo of insurance, is people now realize that there's a limit in what can be covered, what cannot be covered. SHA does not have pre-existing conditions. As I have told you that we cover everything. Any condition that you have, we don't say this one we are not going to cover. SHA does not have also age limit. From day 0 to 90, 100, 120, it doesn't matter. So there's nowhere we will tell you you are above this age, we can't cover you. So we don't. The benefits and the tariffs is something that is not under small print. They are gazetted. They are published. There is an opportunity to amend through petitions to the committee. So it is an open system, a democratic system, where you have a committee that sits, that you can actually go and say, there is this condition that you have missed, or there is this amount is not enough for this condition. Can you please adjust it upwards? So as Kenyans, we have that ability to go and say, but when you look at other insurances, if you realize today, if you need dialysis, there's no one who will cover you except SHA. None. No other insurance will cover you. Why? Because they will look at the premium they should ask you for. And for private health insurance, the premium is probability. If the probability is 1, then it means dialysis, they will have to pay $1 million plus a year. They already know. So because your probability of dialysis, requiring dialysis, is already 1. It's not 0.00 something. So their premium is calculated in such a way that they will have to charge you for the benefit payout that they expect, which is $1 million plus, plus now for other conditions that might arise, plus now their profit or return. Then they will ask you for 2-point-something million as a premium. Hence why they just say we don't cover this.
Yeah,
it's easier.
Or they tell you, if you have pre-existing conditions, I speak as somebody who has 10% of whatever it is that you cover, the total sum of your cover. Meaning, if it's 1 million, the maximum is 100,000 maximum.
But on paper, you have 2 million limit.
Yes.
On paper. But if you happen to be in a hospital and your cover is $1 million bill,
yes,
they can only pay
that 10%.
That 10%, which is 100,000.
That they tell in advance. It is 10%. You see, when SHA gets bad press, and it used to get it very often, as I said, the noise has reduced. It is published. It is known.
Yes.
Do you actually get publication where people are saying you have worked? We see it, but do you people get to hear people saying, this SHA thing, haki kusema kweli, it works?
Yes, we receive. I received letters from patient groups. I received letters from doctors. I have met with hospital med subs in public hospitals who for the first time see resources that they have never seen before. So they have an opportunity to improve on service delivery. It's just that maybe we don't shout and say we have been praised by city or we have been praised. So what has been happening is working just silently.
You know, it's interesting because when I asked this question.
Yes.
Every time somebody says something which is positive about SHA, it's either pandering to the government.
Exactly.
Yes. Or you've been paid, okay? Or this is just positive propaganda on behalf of the... But I have a friend. He's somebody I've worked with, and he was unwell.
Yes.
Now, he has actually documented the experience about SHA. It's called Mark Bichache.
Yes.
He actually wrote it down, detail by detail, what SHA paid, what his private insurer paid. So I know, because he's somebody I happen to know. So I know it's out in the open. But personally, every time it comes up, I also say, I have two relatives whose bills, one actually passed away, but whatever bill they had was paid for. One underwent a surgery recently. It was paid for. So every time the conversation is had, I'm at odds and I say, okay, what specifically are we talking about? Because as any system can fail, any system can have a problem, but what is it that the system promised that it is not delivering? Because if it's not working, then that is what would qualify as not working. But when I read about someone like Mark Bichache openly, because it's the public domain, what I'm saying.
Yes.
And he talks about, and this is somebody who's a communication expert. He's not somebody, he would not say it because he has been paid to say, I know he was sick, I know he went for surgery, I know the surgery was successful, I know. Why? Because he told me. Okay? Is it possible that from what you are saying, Daktari, is that at SHA you try as much as possible to hear what people say and to also try and respond? But you may respond by doing, but do you respond by telling the public the things that you are actually doing regularly so that they can actually understand?
Yes, we try to communicate in terms of what are the things. We haven't done the best out of it. There's also some one other thing that people don't realize, that we have been on a transition, trying to recruit, trying to address this issue of staff transition. So we have finished the first senior management level, from CEO, director, deputy, assistant director level. So now we are heading to the second layer of staff, which hopefully once we are done, we will have an organization now that is fully ready, with no having staff that are not yet sure, am I remaining, am I around, am I going home, or am I going to public service. That transition bit is finally coming to an end, and you will see a lot more visibility when it comes to SHA communicating, but not just communicating, but communicating to the positive. Where there are issues, every day we try to address, because when we pick a problem, we are able to pick out where is this issue that needs to be addressed. And I agree with you, there are individuals who, if you say I am okay, or I have been served, you are told, oh, you are in government, you are this, you have been paid. But the reality and the truth is, if you walk to KUTRH today and go with a camera and look at the number of people that they serve in a day, 98% use SHA. And that one I can challenge anyone. Go with a camera, ask every patient who walks in and walks out of that hospital, what have you used to pay for your services? They will tell you SHA, 98%. So you see, 98% of the people who have walked in and out of that hospital are not very few people. They're in the thousands. And that is now what we see every day. The number of people who are getting, they have 200 radiotherapy sessions. all paid for by SHA. There is no private insurance that will pay for that. Cancer, how?
Actually, my mother is a very big beneficiary of these payments that Dr. is talking about. When she used to go for radiotherapy. Yes, and chemotherapy.
Yes.
Yep.
So you see, those are conditions that generally you will be left to your own. So you are. It is, and that's why we keep on saying that to even increase that benefit further and make it more the limit, so that you don't exhaust per se. We need every Kenyan at least to contribute what is within their ability. If that happens, and we have that authority, the committee led by Professor Jaoko,
right,
we are able to petition and say, okay, please increase, add this. I believe with time we will be able to even move away this verticalization of certain diseases and make all of them integrated under SHA. Instead of saying, today we depend on US to help us with this, tomorrow when they remove the plug out of it, we are stranded. So we are able to reclaim that sovereignty and say, okay, we have a cover that at least covers everyone. And this is for everybody, irrespective of who is in government. Because you see, these things are perpetual. They don't end it today because there is a new government. Once the system picks and it continues and it's improved, it remains perpetual. And you will realize, go to places like Thailand, they can have coups, military taking over, but their UHC never changes. They can have a king, they can have elections. None of those governments who come in touch
the healthcare,
the UHC,
or the education system for that matter. Well, yeah, I'm just adding. So
yes. For Thailand, that has been, many changes have happened. Military has taken over, went back to civilian monarchy. The UHC remained. If you go to the UK, the NHS, you can make noise however you want, whether you are in conservative or Labour. The fight is who is going to add more resources.
Okay.
That's where now public ownership comes in. And public ownership can only come in when you are also putting in, you are contributing, you are a member. So you start demanding and saying, this benefits is not enough. Can we adjust? Can we move in? And now it's not hearsay, it's not rumors. You come with facts, you come with figures, you come with your economist, you come with your actuarist, and we'll have that discussion. Unfortunately, we haven't had that debate. The noise at the beginning was propaganda. Now the little that's there is on operational issues, where you'll find the biometric is not working. You'll find this. So every day we are trying to solve most of the operational issues. But we need to have this national debate to say, is this what we need? That how do we add resources to it?
Daktari, there's a comment here by David Chumo. Anasema is it still or still? But anyway, he's saying, I'm assuming it's still level 2 facilities doing normal deliveries but not being paid by SHA. They have disabled bed capacities. David anaongelelea nini hapa daktari?
Okay. So this is the other thing that people haven't realized, that the way the law has been designed is in such a way that we have delegated some of the authority NHIF used to have to other organs, including this committee that I talked about. Previously, it used to be NHIF that used to determine what is the premium, what is the benefit, and that was it. You had no say. There was no discussion. There were no meetings to stakeholders or anything. So the same thing has happened when it comes to facilities. empaneling, and onboarding. So this is within the Kenya Medical Practitioners and Dentists Council. So as per within their law, level 2 facilities should not have beds. Hence, they shouldn't be doing anything which is inpatient.
So no admissions?
No admissions. As per the law, it's supposed to be an outpatient center. And in any way, they also close dispensaries.
They have set working hours?
Yes.
So essentially, they are what we used to refer to as dispensaries.
Yes. So now when you tell me that you have beds and there's no one working at night, who have you left the patients with?
It's a valid question.
So what SHA does not do. So it is KMPDC that says this facility does not have beds as per our license. And it's time we started working within the legal framework. If you want to become an inpatient, there are norms and standards. Putting a bed is not equivalent to you meeting the requirement. That's not it. You must have the resources, the human resource to work in that facility, to be able to do the night shift, day shift, able to handle emergencies. Then you can say you are now level 3, upgrade it. So that's where Steve Chumo is coming from. It's not SHA, it's KMPDC.
So
it's the regulator who said it's the same thing for you. Now you see, you can't say you are radio because you are beaming on YouTube. You don't have a license for radio. So it's the same thing for those hospitals. If they want to do certain services, all they need is to write to KMPDC, get the upgrading that they require, show they have the resources, human resource, and the equipment required, and then they proceed.
So if a mother happens to deliver at a level 2, ajia posha italipa?
No.
Okay.
Because that's not the services that you have been licensed to provide. Yes.
Even if it's an emergency, like...
Now that's different emergency. But it can't be a normal day-to-day activity. Yes.
Okay.
Dr. We've said some fairly nice things about SHA.
Yes.
Now let's talk about some things which may not necessarily be very nice.
Yes.
As an organization, do you have a system that determines what it is that has been said that requires looking into? And what process do you have or follow to look into these things? And then lastly, how do you talk about the things that you have found that required looking into, rectifying? How do you then broadcast it or let it be known that these things have now been dealt with?
Our communication. That sounds like a communication strategy and plan.
Yes, that sounds like a question that is being asked of the chairman. Yes.
Yes, we have. So what we face are two kind of challenges. There is operational challenge that is unique to an individual or a facility. An individual, sometimes, as I have told you, is your fingerprint cannot be read. You see, that's unique to you, and maybe to someone else and someone else, but the others will have no issue. So when you raise that, all we need to find out is if it is a genuine case, then you are whitelisted. So you see, we might not be able to come back and say we received this noise and this is how we solved. So we will just proceed. Life goes on. But there are issues sometimes which are policy related, which now is made an adjustment. For example, when we increased the ICU, there was a communication to it that it's 4,000, it has moved to 28,000. So that now that is done, the initial, when you address it, the you would find at that time there are many other negative 1,000 stories which are put out to drown what you are communicating, so that it's not seen that you are saying something positive. The others need to come in. We have had our weaknesses, and I think it's something that we will improve on from the teams that we have now recruited from the senior management. I'm hoping to see a little bit more visibility in terms of addressing, saying, communicating that this was a problem, this is what we have done, this is how we have solved, these are the issues. I'm hoping to see changes, a lot of changes.
See, many of these questions and issues, when they come up, they'll come up with reference to a specific facility.
Yes.
Okay?
Yes.
Now, when you do your QA, QC,
yes.
Okay, should this not be a primary focus where when you're looking at health facilities, again, you tell me that's a KMPDC problem. It is largely that. But when you look at what is referred to, forget these general statements that pundits of social media just talk about generally. I'm talking about issues that are raised specifically within a hospital setting, because somebody has gone to hospital and whatever took them there or the need they had was not met as it should. Now, a system that actually collates these issues and a system that also addresses them, so that when it is raised, you can tell this is what was raised and this is what we addressed.
Yes, with the new department that we have, provider relationship, we are actually segmenting the providers and having relationship managers, so that there's someone who is able to address, so that we know this area or this group, all your issues, this is your person to. So your person two will receive, the relationship person will receive those issues. If there are things that it's due to lack of knowledge, they will be able to sort it immediately and explain and tell them, this is the issue, this is what you need to do. If it is something that requires a little bit more address, then they will escalate it to the senior management to find out a solution. If it's beyond the organization, SHA, then now we can escalate it to the Ministry of Health. Like this issue of beds in level 2, that's not something that's within the purview of SHA.
No, it is not.
That is something that needs to be addressed through the Ministry of Health and KMPDC. So we will escalate and say, this is a problem that we need to address. So that needs to go to the ministry to find out how do we solve that issue. And now the ministry will come up with an policy to say, yes, we can exempt, no, we can't exempt. Yes, we can exempt for this condition, no, we can't exempt for this condition. So it's something that can be addressed, because SHA cannot just wake up and say yes, because that decision of empaneling in law is under KMPDC for now.
You know why I asked the question? Health is devolved.
Yes.
Okay?
Yes.
Now, because it's devolved, when you talk about the disease burdens that people have across the country, they will differ.
Yes, definitely.
They are common diseases, but they will differ.
Definitely.
Now, it is these issues of diseases that take people to hospital.
Yes.
And the challenges that they meet or they reportedly meet are what now forms the basis of what we see in social media and everywhere else.
True.
A counter is always necessary. One,
yes,
from a position of communication.
Yes.
Because the hospital do not get the fallback.
Yes.
It comes back to SHA.
True.
Yeah, it is. SHA is not working. It's not that the hospital I went to had this problem. It is SHA is not working. And that is the reason why I'm addressing the question to you, because when anything goes wrong within a health system, the blame will fall squarely on the shoulders of SHA.
I agree with you 100% that we have become the carriers.
Yes, you are.
Of the whole health system.
Yes, you have.
All the burden.
Yes.
Of the health system.
Yes.
Even when nurse does not report to work.
Yes.
SHA does not work. Is true, but we need to address some of the issues which are policy related, but public also now will have a feedback mechanism to us on facilities that are mistreating them, so that now we have the power to take action against that facility. Either suspend them from providing services because of their transgressions as per the contract that we have, or find a way of improving service delivery. The next step we want to put up is a way of even identifying which hospitals we have contracted. Because at times also someone walks into a facility that we have not contracted, then says, I have SHA. Then he's told SHA does not work. Now,
instead of saying we are not contracted.
Thank you. Yes. Instead of the hospital saying we are not contracted by SHA, go to the nearest facility that has been contracted. But what do they say? SHA does not work here. So the person will go to social media and say, SHA does not work. But without realizing that they have gone to a facility. Same thing happens with PHC. Someone walks to a level 6 hospital and wants to get primary health care, outpatient treatment, while level 6 should be for referral. That you have been referred. So now when you are told PHC, you see, then they will not tell you we are not being contracted for primary health care fund. They will just tell you, no, outpatient, you have to pay. Then the person says, why? Then they are told, but your card doesn't work here. Then they say,
SHA doesn't
it's useless. I have contributed for a year and now I can't get services. I agree.
You see, every health facility,
yes,
at some point will send an invoice to SHA.
Yes.
Because essentially, it's a credit facility.
Yes.
They treat,
yes,
they invoice,
yes,
they're paid. When you're paying, an opportunity with a new system is an opportunity for data collection.
Yes.
Because it's a path that had not been trodden before. So all the things that are right, good, and then if you look at the diversity of our counties, hence the disease burdens and so forth, there's an opportunity to actually understand all these nuances and details, so that even you as the person who actually foots this bill, with time you'll have a very, very clear idea, and you'll have very, very clear patterns as to what you pay, how you pay it, why you pay it, and all these things. Why am I saying this? I'm saying this because a system that is as robust as what you have told us SHA is not a system that is going to end tomorrow. If it is to serve people into posterity, then the foundation has to be an extremely solid one. So that when people talk about a reference point, you know, you say, why don't we look and see? And you know, this is what we're dealing with here. But if the opportunity to collect this data is missed now, there are very many things in the future you'll be grappling with it, but you know, we had this a long time ago, but you never collected the data, you never archived it, so you do not have a reference point.
No, yes, definitely we are able to pick how the utilization is, even now. 1 year down the line, I can tell you which county receives the highest amount of money, which hospitals receive the highest amount of money, which condition has the highest payout ratio, how many patients are on dialysis across the country, how many patients have cancer, how many patients, new ones, are being onboarded every now month on month. How many new Kenyans are registering daily? How many are paying their premium daily. So this is data that is available to us that we keep on looking at, and that's why that committee will have the numbers, and hence why I said when you go to that committee, you will have to put in your numbers and say this is what we can cover. So even as we continue, we can see where the burden is, where the challenge is coming from, where the utilization is happening. So with the new branches now that we'll have, we'll be able to now pick facility by facility, address their concerns, pick Kenyans' complaints, put proper branding for each facility, which services that they have been contracted for by SHA, so that when you walk in as a patient, you can actually look at and say, oh, they have not been contracted for outpatient and I need outpatient services. So then you can either walk out or you can proceed, knowing fully well that this is what this facility has been contracted for. Yes, there is a lot, and as you said, this is not something that's going to end tomorrow. This is for posterity, and hence the reason why we just need to onboard every Kenyan. At the least, that primary health care is actually supposed to address 85% of our health needs. 85% of our health needs will be addressed by the primary health care. So then the question is, what you are now trying to grapple with is just the 15%. And the 15%, the best way is haba na haba ujaza kibaba. So you pay what you can, I pay, you pay, your house help pays, your gardener pays. Then we have a basket that is able now to take care of the country, all of us.
Daktari, you see, KRA has got, and I think something Siti was mentioning earlier. For example, Kenya Revenue Authority, they usually do lots and lots of advertisement and information, infomercials. They will send via email. Ukiingia pale kwa email, unaona KRA na kukumbusha, by the way, file your taxes. Ukiingia kwa YouTube, for example, utakosa an advert or two of KRA, especially wakati wa inaitwa nini hiyo kitu, tax returns. Has SHA come up with such kind of advertising or infotainment, infomercials, just to remind us that, guys, first of all, register with SHA. Then number two, these are the services under SHA. So that we don't have Mbuvi with a cold going to Kenyatta Hospital and then
say SHA does not work.
Do we have that kind of communication?
We have not yet put out.
Okay.
But do you have the plan to put it out? Yes. Are you for now limited by the transition? Yes.
Okay.
Once we are over, as I have told you, we'll be able to do all these things in terms of putting out all the necessary information. We try regularly to do through social media currently, but there is a lot more that needs campaigns that need to happen. There is education, and I can tell you, I see many people, including doctors, who still don't understand.
Actually, I knew a lot about, see all these things you're talking about, sijui referral hospital, level 1, 2, 3, zingine nimezijua nikuwa mtu mzima.
Exactly. So there is a lot of communication and education that needs to spread to the community level. Which needs to happen. Yes, and it will happen. It's just that the time just a matter of time. Yes, City will tell me when. This time never comes.
No. Yeah.
Because it's 1 year down the line.
No, Dr. I'm not going to go to when.
Okay. You are a very scary creature. Kila mtu anakuja hapa, City this.
I am not a scary creature.
You are not.
No. You see, let me ask a favorite question of mine. Okay? A system such as this one, don't wait for people who are long in the tooth like myself to start grappling with the details. It is something you should talk about students, whether it's at university level, TVET level, secondary school, so that as they grow, because they'll be of age,
yes,
and they're already dependents, so they're already in the system, so that it's something people grow up understanding. This is how this thing works. When they're now of age, the questions will be fewer, and because they will have understood the questions that arise are based on expectations, and those expectations are not necessarily based on what SHA stands for.
Okay.
They are based on what people expect.
So you are saying campus level education?
Yes. These fellows are soon going to go into the job market, and they're of age and they're adults.
Yes.
You want them. You see, part of the resistance is people feel, why am I paying for something and I don't know what I'm going to get? So these are things that are explained early, discussions had early, so that by the time they're paying, they have a fairly clear idea what it's about. If they don't have an idea, they'll oppose it even if it's good for them.
Yeah.
Actually, I agree with you, because most of the young people keep complaining about black tax. But the black tax they talk about is their parents. And one of the biggest needs of their parents is healthcare.
Oh, yes. It's true.
Yes, it is. Yes, it is.
It's healthcare.
Yes, it is.
So you see, sometimes they don't connect that the need, because your parent can't get private health insurance because of pre-existing conditions or ages, all that.
And yet SHA could come to your aid.
Exactly.
It will reduce the black tax. Daktari,
yes,
we have come to the end of the show.
Thank you.
Thank you so much. Parting shots.
Please register *147#. Please pay Lipa Pole Pole. You have that option. You can pay daily, weekly, monthly, so it's better to just pay. Please update your dependents within the system, so that you don't run into trouble when you are at the hospital level. Thank you very much.
Thank you so much. Salam Zimfike Abdullahi Haji Bishar, I saw your comments. Thank you so much. Josegi as well, you're saying that you're watching from Meru County. Asante sana. And we also have Gyoko Mwai, I see you as well. But this is where we come to a close, man.